Welcome everyone to our webinar Wednesday for Kidney Cancer Awareness Month. Today's webinar will be covering just kidney cancer basics, and it will give us an opportunity to ask questions of our speaker about everything that we want to know about kidney cancer. So just a reminder, if you are joining us on Zoom, please make sure that your microphone stays muted when you're not speaking. We are streaming this live to Facebook, and it will be recorded and added to our YouTube channel later in the week. And if you have questions during today's talk, please use the chat box function to submit your questions. If you're joining us on Facebook Live, you can submit your questions in the comments section. This webinar Wednesday is brought to you by the Office of Community Engagement and Cancer Health Equity at the University of Chicago Comprehensive Cancer Center. Our office serves as a bridge between cancer researchers and clinical faculty at the University of Chicago and our larger community. I do want to introduce today. So on these webinars, you normally see myself. My name is Aaliyah Poulos, and I am an education outreach specialist. And you also see our director for community outreach and engagement, Ms. Gina Curry. A lot of you are already familiar with us already since we're on these webinars regularly, but we have a new member of our team, Ms. Erica Rodriguez, who is joining us as a Latinx outreach specialist. And Erica just joined us yesterday, so big welcome to, or not yesterday, earlier this week on Monday. So big welcome to Erica. Thanks for being here today, Erica.
Oh, thank you. Thank you. I'm glad to be here.
Great. So you'll see Erica around more on our webinar Wednesdays, and you'll probably receive some email communication from her. So big welcome to Erica, and thanks again for being on our team. Our speaker today is Dr. Walter Stadler, and he's going to be just speaking to us really frankly and have conversationally about kidney cancer and what we need to know and some basics about kidney cancer. And I'm going to stop sharing my screen now so that you can see our speaker. And I'm going to pin his video so that will be what we see. All right. Hello, Dr. Stadler. Thanks so much for being here today with us.
Thank you, Leah. It's a pleasure. So, I want to be reasonably informal here. We have a relatively small group of participants, and so I'll talk a little bit about kidney cancer in general, but want to leave plenty of time for each of you to ask some questions. So, just as a little bit of background. I'm a Chicago boy by birth. Lived here essentially all my life, and I came to the University of Chicago more than 3 decades ago as a trainee in hematology oncology, and have stuck around ever since. In that capacity, like anyone that sticks around at an institution for a long time, I've had a number of different roles. I've had a role as a physician, obviously, who has an interest in genitourinary oncology, that is treating patients with kidney, bladder, prostate, and testicular cancer. I've had a role as a clinical researcher where I have contributed to development of novel treatments in kidney and other cancers. And I've held some administrative hats, including deputy director for the Cancer Center, and now more recently as a dean for clinical research. Now, today's topic is kidney cancer, and what I would say is that the changes that I've seen over the last quarter century in terms of how we diagnose, manage, and treat patients with kidney cancers is nothing short of amazing. When I started in this field, we literally had only interleukin-2 and interferon, which some of you may know is some of our original immunotherapy, but they were toxic and typically didn't work very well. And so we essentially started, when I started my career, with few, if any, treatments. And I spent probably the first 10 or more years of my career conducting various clinical trials with various drugs for patients with kidney cancer to little or no avail until the recent era, in the last probably 10 to 15 years, where we now have a wide variety of drugs and agents for treatment. And perhaps we should start, though, before we get to that, a little bit in terms of what is kidney cancer, and how do we diagnose it, how do we get to it. So kidney cancer, pretty simply, is a cancer that arises in the kidney. And interestingly, it is a group of highly related diseases and not necessarily all one disease. Like many of our cancers, it is a cancer that has the most common version is called conventional or clear cell renal cancer. But there are literally a dozen or more other renal cancers that are closely related, but that have slightly different biology and slightly different incidence in patient populations. And as an example only, there is a form of kidney cancer called medullary kidney cancer, which specifically afflicts patients who have sickle cell disease or sickle cell trait, which, as many of you know, is particularly prevalent in our African American population. Now, the most common presentation for kidney cancer is actually twofold. One is hematuria, or blood in the urine, which almost always needs to be evaluated in patients. And the second is when patients undergo a CAT scan for an unrelated reason, and a mass is found in the kidney. And that mass then needs to often be biopsied and diagnosed. And that is happening much more frequently these days, mainly because we are conducting so many more CAT scans for all kinds of reasons. And I would say one of the important lessons over the last 2 or 3 decades is that some of these lesions that are small can simply be monitored without any kind of surgery or intervention, because they are unlikely to impact the patient over his or her lifetime. Now, for patients that have larger disease or that on biopsy appears to be more aggressive, we generally treat these with some kind of surgical removal or surgical resection. And I would say one of the major advances over the last 2 or 3 decades is number one, that we remove these tumors through laparoscopic procedures rather than open surgery. And number two, our surgeons have learned how to do partial nephrectomies, or resection and removal of only the tumor and preserving some of the remainder of the kidney, which is critical in regards to maintaining kidney function and preventing things like kidney failure or poor renal function, which can be associated with other medical problems such as hypertension. Now, if kidney cancer spreads and becomes metastatic, I've said that we have expanded the horizon of treatments. Unfortunately, we don't yet have curative treatments, so that patients that have metastatic disease, we don't necessarily have good treatments that can make the cancer go away or stay away. But we do have, as I said, a large number of different types of treatment and even more emerging therapies that we are developing. So the first class of treatments that we have at our hands is a group of drugs that are called VEGFR inhibitors. Most of these are pills. And essentially, these are pills that attack the blood vessels that feed the cancer. And these are designed to slow the growth of the cancer and are quite effective in regards to prolonging survival and causing some tumor shrinkage and preventing progression. The second group of therapies is a group of therapies called immunotherapies, or treatments that stimulate the immune system to fight against the cancer. And we have a number of drugs in that category. And now more recently, we have demonstrated that combining these two classes of drugs, these VEGFR inhibitors and these immunotherapies, actually is a benefit and provides enhanced survival over using just a single agent, such as the anti-angiogenic agents. We also have some newer treatments that look promising. There are drugs that are similar to the interleukin-2 that I mentioned. That was the only drug that was available when I started, but that is now in essence a version that is much better tolerated. And we also have a set of drugs called mTOR inhibitors that by themselves are perhaps not as good as we would like, but that do have occasionally dramatic benefit in certain renal cancer subtypes. And then finally, we have a new emerging drug that's called a HIF inhibitor that in reality attacks some of the fundamental biology that leads to kidney cancer. And really, I should have mentioned that one of the other major events that have occurred over the last 2-3 decades is a much better understanding of the biology that underlies the development of kidney cancer, and which has helped us and led to the development of some of these drugs. So, being a professor, I do have the potential for droning on and could speak about this literally the rest of the day. But I find that in these kind of environments, it may be easier and better to get you to ask me some questions, to begin to ask the things that you're wondering about most, and to then make this a little bit more interactive and address the things that are most important to you.
Great, thank you so much, Dr. Stadler. So I have two questions in the chat box that were sent to me directly, and then if anyone else has questions, please again use the chat feature or just feel free to unmute yourself. But so I have a question from the chat box that I wrote down here. It said, so you talked a little bit, it asked about symptoms, and you had talked a little bit about blood in the urine, or if obviously if you find a mass through a CAT scan, but can it go undetected? Like, is it possible that you can have no symptoms for kidney cancer and it goes completely undetected?
Yes, unfortunately, like many of our solid tumors or cancers that arise from some of our organs, the kidney itself doesn't have a lot of pain sensors, and the cancer can grow with limited or no symptoms, until there's evidence of progression, or the tumor basically gets big enough to cause things like hematuria or abdominal discomfort or things along those lines. And there is, unfortunately, not a lot of good early detection, or for that matter, early diagnosis for this particular cancer. Now, that being said, I think that one of the other things that we've begun to understand a little bit is that there is a small group, there's a small group of patients who have a genomic predisposition syndrome. In other words, they carry with them genes that puts them at a higher risk for developing cancer. And those families, there may be a indication for conducting, early detection and surveillance with ultrasounds and CAT scans and things like that. But the disease itself is too rare to do, CAT scans in everybody for detection purposes.
So when you say people who may be genetically predisposed, is that like people who have had multiple family members with kidney cancer, or is there, and I know that you mentioned sickle cell, is there any like genetic test that someone can do, or is it just kind of knowing your family history?
Part of this is knowing the family history. And most of the families that we recognize have a clear history of kidney cancer within their family, not necessarily other cancers, but specifically kidney cancer. We don't test everybody, but we're becoming more and more aggressive in terms of testing for some of these genomic factors when we see patients that are younger than the average, or if they do have a family history. And typically, this is a disease of patients in their 50s and 60s. And so when we do see younger patients, we tend to be a little bit more aggressive these days looking for these genetic factors.
Okay. Let's see, we've got a couple other questions here. The first one that I see here, is there a difference in treatment if it is a clear cell versus medullary cancer?
Yes, it is. I mean, the medullary renal cancers tend to be more closely related to some of our urothelial or bladder cancers. And we tend to treat them, with similar drugs. Medullary cancer, though, has the tendency to be a very aggressive cancer, and one that does not respond well to some of the treatments that we currently have available for the more conventional or clear cell cancer.
Okay, and I've got a question here. Does having another type of, genitourinary cancer, like bladder cancer, make you susceptible?
It's genitourinary. It's basically, these are the big words we like to use, makes doctors look a little bit smarter than we actually are. Genitourinary is essentially any organ that is connected to the urethra or is connected to, the urinary system or the genital system. And as I said, us genitourinary oncologists, the diseases we deal with are kidney, bladder, prostate, and testicular cancer. Having a genitourinary cancer other than renal cancer does not put you at a higher risk per se. I would state, however, that from an environmental or a medical history perspective, one of the biggest risk factors for things like bladder cancer is smoking. And smoking is also a risk factor for renal cancer. Not as much as, for example, lung or so, but it is a risk factor. So there we do see some association, but it's an indirect association.
It's funny because every week we have someone talking about a different cancer. And we say, well, what are some risk factors? And smoking comes up every week, not just lung cancer. So if people take nothing else away.
Yes, smoking and obesity are, the two major preventable risk factors for the vast majority of our solid tumors.
Okay. And I've got a question here about dialysis. Does being on dialysis make someone more susceptible to renal cancer?
The answer to that is a definite maybe. And let me explain that a little bit. Patients who are on dialysis, long-term dialysis, more than 5 or 10 years of dialysis, which in itself is rather unusual. And they still have their native kidneys in place. In other words, they weren't removed for any kind of reason. Can develop a disease that we call cystic disease of dialysis. That is, that their kidneys can develop these non-functional cysts. And over time, there are some cancers that arise within those cysts. So is it a risk factor of dialysis? Yes, but it's a rare, a long-term risk, and the other problems with dialysis are much, much more important than this particular problem.
Okay, and I have a question that says, how often do resected cancers end up recurring, and how long does it typically take before you know if this will happen?
Yeah, so this depends a lot on how large the tumor is and how nasty it looks under the microscope. And this is what we talk about in terms of staging and grading. As many of you know, we tend to stage our cancers based on the extent of the tumor. And one of the things that I've noticed when we talk about staging is that staging is really most useful, for patients with a localized cancer that helps us predict whether the cancer will actually recur or not recur. One of the things that is, and this is a little bit, I'll get back to answering the question, it's a little bit of a sidetrack, but one of the things that happens in terms of staging is that anything that is spread is called stage 4. But stage 4 includes a wide variety of patients, anyone that has one tiny little nodule in their lung to patients who have widespread end-stage disease. And this is a wide variety. So saying stage 4 in and of itself actually tells us very little about the patient. I make this a side note because I run into that all the time. Now, when we're talking about staging in regards to surgical staging, the staging of 1, 2, and 3, it does make a difference. But importantly, there's also importance in terms of the grading. And the grading is essentially how nasty does it look underneath the microscope. So for small stage 1 tumors that are low or intermediate grade, cure rates are above 90%. The vast majority of those patients will never have a problem. On the other end of the spectrum are patients who have locally advanced disease, for example, disease that is outside of the kidney and into some of the regional nodes. And those patients, even though we remove it surgically, and the surgeon says, we got it all, the chances of the cancer coming back can be pretty high, as high as 70 or 80%. And this gives me an opportunity to talk a little bit also about, why does cancer come back and what do we mean by it coming back, right? The surgeons gotten a little bit better over the years, but certainly when I started, they had a tendency to say, yeah, we got it all. Good job. What that means is that we remove everything that we can see. And we know that if the cancer is more extensive, for example, has spread into the local lymph nodes, what that tells us is that there is a relatively high probability that there are microscopic cancer cells elsewhere in the body that then over time grow and give us a problem. Now, with kidney cancer, if we are in that latter group, in other words, you're a patient that is in essence destined to have recurrence and the cancer shows up again later, or as we say, metastasizes, that typically occurs within about 3 years or so, and the vast majority of kidney cancer patients, if they recur, tend to recur within 5 years. It's also, however, I always hate to use the word interesting because you never want to be an interesting patient, but it's an interesting disease in the sense that this is a cancer, one of our cancers, that can actually recur or come back 10, 15, and I've even seen 20 years after surgery. We don't really understand why. We don't understand why there are some of these patients where somehow these microscopic cancer cells that must have been there 15 years earlier now took that long to grow. Was there something about the immune system? Was there something about where they were? We don't necessarily understand that, but that can happen, at least in a minority of patients.
I've got questions here about treatments, and I'll just kind of combine them. So you had talked about immunotherapy as treatment for renal cancer. Are chemo and radiation usually used as therapies, and also kidney transplants, using those as a type of intervention?
All excellent questions. So kidney transplant is rarely used, but occasionally we will see patients who have a kidney cancer in one. They had it removed. Because they have perhaps some genetic predisposition, they developed it in a second in the other kidney, and then they need both kidneys to be removed in order to treat effectively. And those patients, if they don't develop metastases, after usually 4 to 5 years, are potentially a candidate for kidney transplant. I would say that is extraordinarily rare, and we have those discussions and see patients like that maybe once every year, once every other year or so. Radiation does play a major role, but like most of our radiation, it is utilized for local therapies. In other words, if a particular metastases is painful, is causing problems, we do use radiation therapy for that particular area. One thing that has changed over the last quarter century is when I trained, the teaching was that kidney cancer was radiation resistant. It didn't respond to radiation very well. But that is not necessarily true because these days we are utilizing more focused high dose radiation therapy, which is effective, even in kidney cancer. The term chemotherapy is in some ways, and some of my trainees and fellows know this, is one of my most hated terms, but perhaps not hated the way you may think about it. I dislike the term chemotherapy because in cancer treatment, we now have literally hundreds of drugs, some of which are labeled as chemo, some of which are labeled as targeted, some of which are labeled different ways. But those labels don't necessarily correlate or associate with those things that are most important for patients. What's most important for patients is, what are the chances that the drug is going to work, and what are the chances that the drug is going to cause me some side effects? And the label that we use means less than the specifics about that particular drug. And I would say, though, that what most people think of as, sort of traditional chemotherapies or some of the traditional drugs that we have utilized for cancer treatment are drugs that are not particularly effective, in this disease.
We've got a question here about who is most likely to develop kidney cancer in terms of race, gender, or age group.
Yeah, so this is a disease that is more common in men than women. It's about a 2-to-1 men to women ratio. And the most common scenario is people in their 50s and 60s. I've already said that the risk factors, smoking and obesity, are the biggest risk factors. So the most common patients that we see are, obese men in their, 50s or 60s. There's really not much of a race predisposition, except for this rare, I mentioned this medullary renal cancer, which tends to be associated with sickle cell disease and sickle cell trait. But otherwise, there's not as much of a racial predisposition one way or the other.
And then there's a question about, are there overlaps in the symptoms of kidney cancer and other genitourinary cancers?
Yeah, I mean, I think that, in the sense that many of these cancers are connected to the urinary stream, certainly a commonality here is, blood in the urine, or what we call hematuria. So patients that develop hematuria, blood in their urine, is something that should be evaluated. It is, though, not a very specific finding. In other words, the vast majority of patients who have blood in their urine, the cause is a non-cancer cause as opposed to a cancer cause. There's other diseases that obviously do this.
And then you had mentioned some clinical trials. Are there a lot of clinical trials at the University of Chicago around renal cancer?
Yeah, we have a number of clinical trials that we're looking at, and sorry, my cat has decided to join us. We have a number of clinical trials that are looking at novel immunotherapy combinations. So I mentioned, that immunotherapy is a treatment approach, but there's various specific drugs and novel drugs. We have some trials looking at, I mentioned these HIF inhibitors. And so those are probably the biggest category of trials that we have. And then there are, some of our newer, earlier phase drugs where we're testing, novel approaches. So we have a number of different trials available.
Okay, and I've got a question, a personal question from an aspiring physician that we have on the line here. She says, "I would love to know what led you to this specialty, and what do you find most rewarding, and what do you wish you could change?"
Well, the last two are easiest. In terms of what do I find most rewarding is, in many ways, being an oncologist allows us to have relationships and interact with patients and families in what is often one of their most difficult times in their lives. And having an impact, having an ability to be with patients during those times is in and of itself very rewarding. I think I mentioned already the fact that I started my career with essentially no treatments and have now a set of different treatments available for this disease is also an incredibly rewarding aspect of my career in general. Having seen this, having been involved in these developments, I think is, as I said at the beginning, nothing short of amazing. And it is being at the seat of the table, having a seat at the table as these things were developed is just a wonderful experience. I think that also leads to, what we hope for. In other words, the treatments that we have are, not curative, and cure is what we want. We're looking for curing patients with metastatic disease, and that's a word that sometimes was considered a dirty word earlier in my career because it was, thought to be unachievable. I think that, many of us, as we've seen some of the developments, seen some of the understanding of biology, are hopeful. Maybe not in my career, maybe not even in my lifetime, but we're hopeful that this will be possible, if not in everybody, at least in some patients. How did I get here? I was a little bit of dumb luck more than anything else. I started my career knowing I wanted to be in this field. Some of the data on interleukin-2 was published around the time that I was in training, and I was sort of fascinated by the fact that we could, even in a small minority of patients, tweak the immune system to treat for treatment, and that to me was fascinating. And then, some of my mentors, some of the people that I worked with closely were just people that I enjoyed being with, that I liked being with, that I was inspired by. And, that's how I, sort of ended up in this field. I think that, as I tell some of our fellows, in this broader field, not necessarily genital urinary cancer, but not specifically kidney cancer, but genital urinary cancer more broadly. We do a lot of men's health, so I see a lot of men and elderly men, and I actually don't mind and enjoy working with and treating cranky old men. Other people don't, but I'm sort of fine with that.
Well, thank you for that. We got like I said, a future physician, and she said she's trying to narrow down which specialty to go into, so she likes to learn about that.
Yeah.
We've got a question here. Are you more likely to get kidney cancer if you only have one kidney?
Short answer is no, although I guess it depends on why you lost the first kidney. But lack of a kidney for, example, trauma patients who have lost a kidney because of some, traumatic event that it had to be resected are not at an increased risk for a kidney cancer in the remaining kidney.
Okay. And so I have two more questions. One is just a fun one. So I guess the fun one is two people asked me, what's the name of your cat?
My cat's name is Venus. I had no say in what the cat was named. I didn't even want the cat in the first place, but I was overruled.
Well, there you go. And now Venus is making an appearance on your Zoom, so that's great.
Correct.
We all have experience with that for sure. And then, so my last question, more seriously, is just what would you? So I'm not seeing any other questions in our chat box, and I'm just going to make sure everyone else, if you've got a question, just make sure that you get that into the chat. Or again, if you're on Zoom here, feel free to unmute yourself. I'm going to check our Facebook feed really quickly before I move into our last question. Let me just make sure. Okay, I don't see any comments on our Facebook Live. I'm gonna do one more scroll through the chat box to make sure I didn't miss anything. And yeah, I think that's everything. So Dr. Stadler, if you had one key takeaway that you want to leave with our audience, or if you were talking to a friend or family member, one thing you want them to know about kidney cancer, what would you leave them with?
I would tell them that there is a lot of hope. I would tell them that we have a number of ways of treating cancer, kidney cancer specifically, even in sort of the most advanced cases. And as a result, I'm in this business because I'm a hopeful guy. And that's how I approach every single patient.
Awesome. I love that answer. Well, thank you so much again, Dr. Stadler, for joining us today and for sharing your wisdom with us. We really appreciate it.